Welcome to PHM 627. For this class, I'm going to introduce the concept of global health. And to do that, there are a couple of learning objectives. So, the first is describing the history of global health and how it was born out of international health. And then we're going to discuss the mechanism of catastrophic health expenditure and how it affects global population health. And then finally, discuss universal health coverage and how it addresses some or how it tries to achieve social determinants of health. So, starting with the history of global health. So, global health has had a number of definitions. We have one of the earliest definition being in from 2009, and this definition has global health as an area of study, research, and practice that places priority on improving health and achieving health equity for all people worldwide. So, this is a good definition, and it definitely reflects on what global health is, but it does not fully capture the essence of global health. Another definition is from 2018 that looked at global health as being a goal to promote health and prevent and treat diseases for all people in all countries across the globe. So this is another definition that does not fully grasps the scope of global health. This definition kind of tends towards a medical or clinical aspect of it that is much focused on disease prevention and treatment. So global health does go beyond that, and so the third definition from the Duke University's Global Health Institute does a much better job of capturing what global health is in defining it as emphasizing a broad multidisciplinary approach to understanding emerging health challenges, particularly the bit about considering social and cultural, economic, and environmental factors that lead to the underlying health inequities that global health is really tasked to address. So, global health, like I said, was born out of international health. Global health is not the same as international health. For a lot of the times, we used to focus on international health and then moved away from international health and started kind of looking at it from a global perspective. So, the definition of international health is that it is a study of health in countries other than one's own, especially in other countries that are representative of developing world. This is a definition from 2018. In essence, basically, it is someone from from your country, and you are interested in finding out what the health of another country looks like. So this sort of approach to health does not consider how the health of your country may be affecting the health of the other country. It just kind of takes the particularly countries that we call or that has been termed as developed countries, kind of taking themselves out of the equation and more or less kind of focusing on countries that are termed developing countries. So that is the difference between global health and international health. And also, another definition, this is from 2002, says that international health focuses on participating countries with intention of to affect non-participating countries. So basically, this second definition is more or less like looking at it from a I don't want to get to your disease kind of approach, whereby the participating country is trying to make sure that the non participatory country, in this case, the developing countries do not get their bad stuff on them, more or less. Like disease prevention, in the sense that we are good and we don't want you to get your bad on us. So that is a definition of kind of what international health is, and hence why it is not really kind of working out presently, and is more or less being phased out because of that approach to looking at health. So, how global health came to be is global health came from end of Euro-colonialism, in which during this time there was more of a tropical medicine that was being practiced, whereby you had the colonizers going into another country and trying to take care of their health, and it just was kind of called tropical medicine, because for the most part the approach to health was very different from the approach to health of the countries that are the colonizing countries. So then we had international health coming around the end of the Cold War, and now we kind of moved into global health, which is where we are. And it's this diagram says a new world health. We have not quite got there. We are still very much on the phase of global health, but as intersectionality starts to really make its wave, I think we will get to the point of the new world health. Right now, global health still very much has an element of international health to it, in the sense that global health is still disproportionately focused on developing countries more than developed countries. So it's not the way that it was under international health, but it's not entirely out of that phase. So one of the reasons you can watch this video that kind of looks at international health, sorry, tries to define what global health is a short video. So it kind of does put things into perspective. So I said that international health, global health is a little bit like there's still an element of international health in global health. The reason being that tropical medicine and international health very much was born during the time of colonization. A lot of that happened was where you had mission trips that came together, came along with the colonizing generals and that, and so they joined. Kind of, there was a marriage of interest between the missionaries who came to bring the word of God to these countries that they came to colonize, as well as the soldiers who came to make sure that the natives behaved themselves. So there was very much a combination of that happening. And so you had that approach whereby you had the soft hand of whereby we are here to make your life better. That was an approach to mission trip. And the enforcement, you have to act the way that we want you to act. That came with the generals and the soldiers. So, this marriage between them. So, and therefore, international health or tropical medicine at the time served a dual purpose, whereby you had mission work and colonization working very much hand in hand with colonization and international health. So, whereby you had some doctors who were usually not soldiers, but came a lot with the missionaries, and what they did was to kind of gets the people that were in this case working on behalf, working for the colonizers to stay in good health. So you want to get the best out of the labor force in this case being the natives, the native of the countries that were being colonized, and you want to make sure that you're able to get the best out of them. And in order to do that, you want them to be healthy. And so you had the missionary doctors providing health care to the working force in the colonized countries. But what, of course, happened is that it was very much from the approach of profit. You want to make sure that they are healthy enough to continue to do work for you. And this is, of course, looking at it in the most innocuous way or the most benevolent way, because a lot of things happened during colonization, a lot of things that were quite horrendous, and but that was not what the doctors or the missionary doctors focused on. Their focus was to make sure you had a working labor force that would be able to get the colonizers or colonial masters, will get called, the best out of the countries that they have colonized. So this means that whatever services that they provided, healthcare services, was definitely not charity. Charity, it was not. So it was very much trying to make sure that they can get the best out of the countries or the places where they colonized. So you can watch a bit more that looked at colonial medicine and international health. Here it does try to break down what decolonizing global health looked like in terms of looking at it from the colonial entanglement and the history of global health. Now, the reason why it is important to understand global health from this perspective is because a lot of the global health as it is today is not 100% divorced from all of the things that happened during the era of global of colonization. There is still very much a side effect or a byproduct of those time in the present. So you would kind of find most colonized countries performing badly in terms of health indicators or health statuses. A lot of that came, not is not 100% from it, but there's quite a lot of influence that came from all of those years of colonization and all the unpleasant things that happen as a result. So let's get into catastrophic health expenditure, because this is where global health is kind of functioning in today's world. There's a lot of work that is being done in terms of pushing and to address catastrophic health expenditure on the global level. So when it comes to health spending or health financing, there is something that is very, very important in that conversation, and that is fairness in spending. So fairness is a very key dimension in assessing the performance of any country's health system. The reason being that the people who can afford healthcare will be healthy. For the most part, they're going to stay healthy, not so much for those who cannot afford healthcare. So fairness has to come in as a way to making sure that the overall health system of a country or the globe kind of stays fairly healthy as a result. So, and this is because when protecting a household from financial consequences that come from medical care, you are able to have a healthier population in terms of the entire population. So this is something that is very, very important when it comes to conversations about health financing. So one when there is an absence of financial protection on a global level or on country level, what happens is that there is gross inequity that happens, whereby the poorer country household or household of the lower economic status kind of risk slipping into medical poverty trap, and this does restrict their access to health care. It undermines their health status, deepens poverty, and exacerbates health and socioeconomic equity. So that is one reason why it's really, really important to focus on financial protection when we are talking about health. And that is one of the things that global health has really been focused on in pushing countries to really pay attention to financial protection. So, financial protection is assessed in terms of looking at out of pocket spending and how much those out of pocket spending is going to medical care. It's also looking at it in terms of what is the catastrophic payment. So, there is out of pocket spending that in itself is not uh, bad. What becomes a bigger conversation is when does those out of pocket payments lead into catastrophic expenditure. So that is where the conversation really comes down to, and how do you determine when an expenditure becomes catastrophic. So there is a way of assessing it to say, okay, this has now turned into catastrophic expenditure. But one of the reasons why preventing catastrophic expenditure is because if it's not done so, you have people, especially from the lower economic status, getting into the state of impoverishment that happens out of pocket medical care. So, financial catastrophic expenditure is not necessarily determined by how high the health expenditure is. You have to look at it in context. So, there are a couple of things to consider in context. You have to look at it in terms of the region where this is happening and what's the socioeconomic group that we are looking at. So, it's not okay, let me put it this way. $500 may not be a huge amount of money for someone who earns in six figures or seven figures. $500 is a lot of money for someone who is probably making $2,000 a month. Having to spend $500 a month on health care becomes a challenge for them. So that is why when you're looking at financial catastrophe, you are not looking at it in terms of what the expenditure is, but you're looking at it in context. So, and this catastrophic expenditure happens when a household is spending more than a certain fraction of its income and on health, and it's doing that out of pocket. So the way that we assess whether this spending is catastrophic is when a household is spending more than 10% of its total income on health. So when that happens, we look at it as being catastrophic expenditure. Another way of determining what catastrophic expenditure is when a household is spending over 40% of its total income on non-food expenditure. Like food is meant to be the thing that you expect is going to take up the most money and rent and stuff. But when more than 40% of a household income is going to non-food expenditure, you are in a zone where we consider that to be catastrophic expenditure. So, catastrophic expenditure is not related to a country's GDP. So, a country can have very high GDP, and yet you have a portion or a large portion of the country experiencing catastrophic expenditure. So, when we're kind of considering catastrophic expenditure, we're looking less about whether this is a wealthy country, but more of what is expenditure in terms of per capita spending that is happening, especially the portion of the per capita spending that is coming from out of pocket payment. So this is from 2010 that kind of looks at the incidence of catastrophic health expenditure, whereby you have the countries that are in deep red to be spending more than 15 to 45% of its total income in terms of household, and then you have the lighter being less than 2%. So Canada is one of the countries that is doing pretty well, and a couple of European countries are also doing well, and some countries in Africa. South America is not doing quite well, and also a couple of countries in Asia and a couple of countries in West Africa. So overall, there's some countries that are doing well in terms of catastrophic expenditure, and some countries that are not doing so great. So, how do we determine what are some of the determinants of catastrophic expending? So, one is age. A household that has a lot of elderly people in it is likely going to be experiencing catastrophic spending. The reason because of chronic conditions or comorbidity that happens with elderly people. You do also have young children because of the especially if they are under the age of 5, because of all the health challenges that come with being that young. You also have to look at poverty level. As you can imagine, the more the poorer one is, the higher the likelihood of having catastrophic expenditure. And then if there is any chronically sick person in the household, that does affect chances of having catastrophic expenditure. If a household size is large, also, if, for example, if there are 7 children in a family, you would expect there's a whole lot more expenditure that goes into their healthcare versus a household with only 2 children. So that does come into account. And then you do have what is the health system itself? A health system that has a lot of its spending coming from out of pocket spending is, of course, going to be at a great risk than a health system that has a lot of like a universal health coverage that is going to affect catastrophic. And with that, we're looking at the level of prepayment, the type of prepayment, and finally, we have the out of pocket share of the total health expenditure. We do look at health spending as a proportion of the GDP in terms of determining that. So, this is how it looks like in terms of distribution of catastrophic spending across the world. Countries where you have countries, low income countries, having very high in terms of their economic group within the countries. In the low income countries, this is what's happening with and this is what's happening with the middle income countries, and this is what is happening in the high income countries. The low income countries, as you can imagine, are having more catastrophic health expenditure than the higher income countries. So this is a little bit expected, but this is what the data is telling us. So this video does explain how catastrophic health expenditure does affect one's health. So it's a very short video, about 30 minutes, so you can watch it to kind of get a bigger idea of what we mean in terms of that. I'm sorry. So lastly, to the third objectives, we're going to discuss universal health coverage. So, universal health coverage, what we mean when we say universal health coverage is that all people and communities are receiving equitable access to comprehensive health care. And the quality of the healthcare is guaranteed in terms of what they need. And this is something that is happening throughout their life course. And then most importantly, that they are receiving this care without financial hardship. Financial hardship is where catastrophic health expenditure does come in. So, universal health coverage is one of the solutions to catastrophic health expenditure because it does emphasize on receiving quality health care without financial hardship. So, and the reason universal health coverage came into existence is because if households have to choose between feeding or paying rent or going to the hospital, as you can imagine, they are going to forego seeking medical care unless they absolutely have to, which in turn leads them to having a poorer health outcome. So UHC addresses the social determinants of health because it does try to focus on the groups that are particularly vulnerable to poverty and all the other things that make create health inequities. So the values on which UHC is founded on is the right to health. So the WHO defines a right to health as the enjoyment of the highest attainable standard of health, and it's being a fundamental right for all human beings without distinction of race, religion, political views, economic and social conditions. So this is the principle on which UHC is founded on, and also the principle of equity and this principle of solidarity. So this is why USC is one of the ways of addressing social determinants of health because it does emphasize on regardless of one's race or their religion or political view and the gender, social, economic and social conditions, one has the right to receive the highest attainable standard of health. So this is one of the reasons why UHC is one of the solutions to the challenges of social determinants of health. So UAC emphasizes the need for implementing policies and interventions that are intersectoral, because otherwise it's not really going to address social determinants of health. It needs to be very comprehensive. Otherwise, it's not going to address some of the underlying factors that contribute to health inequities. And it needs to do this by fostering a commitment to society in a whole as a way of promoting health and well-being. And it needs to place emphasis on the condition of poor and people who are, vulnerable. So you can watch this video that looks at how UHC tries to improve health. This happens across the world globally. So this is a very short video as well, I think about 5 minutes, that does a good job of explaining the role of UHC and how it's going about doing that. And so, as lovely as UHC is, there is still a couple of challenges to that. And these challenges are very real and they do affect how far we can go to UHC and the reason why not all countries have adopted it. So you have the political commitments to that. Some countries don't really care about that, and so they're not able to, foster enough political commitments for that. And there are within countries very high levels of health inequities, and it takes a lot to address them. And not all some countries are not quite as invested in doing that as they should be. Of course, you have new epidemiological patterns that came in, COVID-19 being one of the ones that kind of threw a big wrench to health in the world. So this coming and presents a challenge to universal health coverage. And then you have problems of exclusion and the lack of access to quality care services that exists everywhere and takes a lot to address them and may not be addressed, something that is very critical to UHC. And then, of course, healthcare continues being very expensive as the year goes, which creates a challenge to universal health coverage, because how do you give everybody quality health care if the cost of health keeps going higher. If a country's health system is also fragmented or segmented, it also makes it, quite challenging. And there's a lack of regulatory capacity. As much as WHO wants to push for UHC, they don't have any legal grounds to do so. So it's completely up to the countries to be able to do that, and WHO cannot regulate how that is done and or decide how to integrate it. So that creates its own challenge. And then some countries just don't have enough money to be able to adequately provide UHC, and that's just a challenge that comes with it. And then finally, you have the social determinants of health. As much as social determinants of health pushes for intersectoral actions to address it, it's quite weak in some health systems. And in order to you really achieve universal health coverage, we need to strengthen these intersectoral actions that is required for social determinants of health to be addressed. So that is still a challenge in many countries. I dare to say in all countries, and therefore it does limit how much universal health coverage can achieve its goals and objectives. So this is where we end. Of course, remember, if you have any questions, please ask and we'll address it. Have a nice day. Bye.